Hello, everyone. Welcome to our October webinar, Glodam Trainee Committee. The topic of the month is Cutaneous Infections in the Tropics, Cutaneous Tuberculosis, Clinical and Dermatopathology Aspects. And we are grateful to be joined by our speakers, who are Dr. Daniel Zuriel and Dr. Caroline Mutio. So, as I have said, the webinar is hosted by Glodam Trainee Committee. So today I'm your host, I'm Karen Waithera. We'll have Dr. Imelda Njiru, who will be taking us through Q&A, and Fortunate Raymond McCoy will be managing the chat function. So Glodam Trainee Committee is part of the ILDS, and it falls under the International Federation of Dermatology. Our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. We have various initiatives, but our key ones are educational webinars like the one you're attending today, networking and collaboration, where we have trainees worldwide, and a podcast series which you can access via the various popular podcast platforms. So in terms of meeting etiquette, your audio will be muted and your camera will be turned off for the duration of this webinar. If you have any questions, kindly submit them via the chat or the Q&A function, and our hosts will make sure that the speakers answer your questions by the end of the webinar. We'll also be sharing further information about the Glodam Trainee Committee in the chat function. So our speakers for today are Dr. Daniel Zuriel and Dr. Caroline Mutio, who I'll go into a bit of information of who they are. Dr. Daniel Zuriel is a consultant pathologist and a board-certified dermatopathologist. He's the president of the African Dermatopathology Society and a senior lecturer at the University of Nairobi, Kenya. He's a great teacher of mine, and his interests are in tropical skin diseases, cancer, wound healing, and psoriasis. Dr. Caroline Mutio is a dermatology resident at Kenyatta National Hospital in Nairobi, Kenya, and she has interest in cutaneous oncology, dermatological surgery, and also how AI can be reimagined to ensure that we get access to skincare in our low resource setting. So thank you and welcome to our speakers.
All right, good afternoon, everyone. Thank you for the introduction, Dr. Waithera. My name is Caroline, and to my right is Dr. Zuriel, and we would like to welcome you to today's presentation. We are going to be covering cutaneous infections in the tropics with a focus on cutaneous tuberculosis, and we will look at the clinical and the dermatopathological aspects of cutaneous tuberculosis. So this is the outline of our presentation. We will go through a little bit about the historical perspectives on tropical dermatology, what we mean by the word tropics and the tropical context of dermatological diseases, the burden of skin diseases in the tropics, the spectrum of tropical skin infections. We'll discuss a little bit about neglected tropical diseases and then get into cutaneous tuberculosis. So I'd like to tell you a little bit about how dermatology as a practice came to be, and it dates back from the 12th century. So that is an image of the Crusaders who are fighting the Holy War in Asia and in the Middle East. And you'd find these Crusaders coming from those particular areas and going back to Europe. And so try to imagine that you are a physician at that particular point in time, and you encounter a patient who has traveled back from these regions, and their skin is marked by very weird looking lesions. The people in the red outfits and the black are what were the middle-age non-governmental organization. They were referred to as the Hospitalia movement, and they formed what we now call the hospices, and they were tasked with taking care of people who came back from the war who had skin diseases, and this was the first structured way of taking care of patients who had dermatological diseases. Fast forward to the 16th century in the era of Christopher Columbus, and Christopher and his friends were feeling a little bit explorative, and they moved around, and in the process of moving, encountered quite a number of diseases that they also took back to their home countries. So this practice of trade and colonization, as well as migration, now introduced diseases from the areas that are known as the tropical areas to other areas that previously had not encountered infections that tended to flourish in areas that were warm and humid and with a lot of rainfall. Still in the 16th century and the 17th century, early 18th century, we have more people moving from the European countries to other areas, to the Americas, to Africa. And in their logs, these people who were referred to as the seafarers, they recorded how they encountered a number of diseases from these particular areas, majority of which were quite strange to them, and most of them were cutaneous in nature. As we progress into the 20th century, we have this gentleman, his name is Sir Aldo Castellani, and he founded the International Society of Tropical Dermatology, which is now referred to as the International Society of Dermatology. And the International Society of Tropical Dermatology was founded on the need for taking care of patients who were in low resource centers who had tropical diseases. And he's renowned for discovering the cause of sleeping sickness. And he spent quite a significant amount of his time studying in East Africa, and particularly in Uganda. In the 20th century, we also have the wars going on. We have the World War II, and there's a book by the name Hunter's Book of Tropical Medicine. And this book was created specifically for military doctors who are supposed to take care of the military personnel who are traveling to these areas. And it highlights the specific diseases that will be encountered in these areas and how the doctors who are going to these areas will manage these diseases, and especially dermatological diseases. So when we talk about the tropics, we are really referring to this region between the Tropic of Cancer and the Tropic of Capricorn. And so it's this region that is highlighted in orange and a little bit of red in the map. And these areas are, the major characteristic of these areas is they tend to have very humid climates. It tends to be quite warm throughout the year, and it also has a lot of rainfall in quite a number of those areas. And this particular environment creates a very conducive environment for quite a number of vectors to proliferate, and in the process also propagate disease transmission. In addition to these climate and environmental factors, we also have some social economic conditions that also play a very big role in how diseases are transmitted, and particularly in terms of poor healthcare, poor access to healthcare. We also have a lot of poverty in these particular regions. And so it's not only the tropics and the environmental conditions that will result in a high burden of diseases in this area, but also the social economic conditions. We also have population and epidemiological dynamics, where these areas tend to be burdened by a very high rate of urbanization. And the urbanization typically tends to come with also poor sanitation, poor hygiene, overcrowding, and this is also one of the key drivers of diseases in these areas. When we talk about the globalization of tropical diseases, what we are basically talking about is how quite a number of factors have sort of propagated the spread of diseases from areas that are normally referred to as the tropical regions to other non-tropical areas. And one of the key examples is this systematic review that was done by Parke et al. It was published in September 2025. And in this systematic review, they reviewed 63 papers that reported cases of refugees and immigrants who had come from rural areas, moving to high-income countries, and majority of the refugees were from typically low-income countries. And one of the things that was highlighted in that particular systematic review was that the burden of diseases from these particular patients tended to be cutaneous in nature, with around 60% of the patients presenting with cutaneous infections, the largest being fungal infections, followed by bacterial infections, scabies, among others. Another factor in terms of globalization of tropical diseases is how climate changes have also driven the expansion of vector habitats, and climate changes are typically characterized by increase in temperature and also high water levels in quite a number of areas. We also have extremes where some areas have also experienced flooding that was previously not a problem in those areas. And this tends to drive vector habitats in terms of proliferation and also in transmission of diseases. Another example is the global report by WHO in 2023, which showed that in North America, more than 75% of the persons who were diagnosed to have tuberculosis were immigrants. And so you can see how migration really greatly influences how diseases are transmitted, because the Americas might have had a TB endemic in the past, but because of surveillance and a lot of programs that have been put in place to identify the diseases and manage them at an early condition, the disease was almost driven out of the country. But with increased migration and movement across the borders, you have diseases being reported in areas that were previously not endemic. So in terms of the burden of diseases in the tropics, we have approximately 900 million people who are affected by skin diseases annually. And this is almost one-eighth of the global population, which is quite a big population. And 20 to 40% of all primary care consultations tend to be skin related in the tropical areas. And majority of these primary consults will be dominated by infections, primarily bacterial infections, fungal infections, scabies, among others. And in Papua Guinea, 30% of the health post budgets were found to be allocated to treating ulcers. And some households in Mexico were found to spend an average of $24 in managing scabies. And this highlights the economic strain of some of these conditions. These tropical infections range from bacterial infections, fungal infections, viral infections, parasitic infections, and the majority of them in the past few years have been found to be fungal infections, and especially in areas with very poor living conditions and poor sanitation. And one example is India. Neglected tropical diseases represent a cluster of diseases that have been identified by the World Health Organization. And some of them include leprosy, we have lymphatic filariasis, we have yours, scabies, mycetoma. And the World Health Organization has tried to target these particular infections because of the effect that they tend to have in terms of the quality of living for the patients that they affect and the economic consequences that come with managing some of these infections. And by identifying these diseases, it has been able to integrate some strategies in identification and tracing the cases and also managing them from the primary healthcare level. We have an app that Dr. Jose has been trying to create. It's an AI app that tries to identify skin diseases. They're in the process of rolling it out, and they should have the results published hopefully by the end of this year. And the app is very important because like in Kenya, it was tried in areas that are considered rural. And this app was given to nurses and clinical officers, basically people who do not have a lot of training in dermatology. And it was found to have a very high the ability to detect diseases was almost equivalent to that of a dermatologist. And it is very important because when the people at the primary care level are able to identify diseases, they are able to refer the patients and also assist in early management of the diseases before they become chronic and debilitating for the patients. We also have the World Health Organization Skin NTD handbook that is readily available, and it's a guideline to assist people who are in the primary healthcare level to manage and treat some of the neglected tropical diseases, which assist in bettering the quality of lives of these patients. So tropical diseases are important because of the effect that they tend to have in majority of our patients. And the biggest one is stigma and discrimination for certain diseases, for example, leprosy. And a lot of work has been done in educating and trying to identify the cases of leprosy, because we find that patients who are diagnosed as having some of these diseases are isolated in their communities, and this greatly influences the quality of their lives. Additionally, we have a really high burden on the households, and it was found by the World Health Organization that more than 50% of the household income in some of these diseases was spent on managing some of these neglected tropical diseases and in tropical diseases as a whole. There's a role of traditional medicine in tropical medicine, and a number of our patients will normally visit a traditional health practitioner before they come to see us. And we don't know how effective their treatment is. We can only speculate. But the trouble with these traditional recipes and treatments is that they tend to result in delayed diagnosis. And so by the time you see a patient, they will really have a lot of systemic involvement because the disease has spread, or they have organ toxicity because of use of some of this herbal medication. And so we have a role as dermatologists in trying to encourage our patients to seek care early, and also educating people at the primary health care level to identify some of the symptoms that they can use so that they can refer the patients early for diagnosis and also for early treatment. So I'd like to take you through the white plague. And the white plague is one of the many names that has been used to describe tuberculosis. It was in the literature, it is reported to have been present from the ancient times in some of the mummies in Egypt. And it's a disease that has been very problematic for quite a number of centuries. In the 1800s, tuberculosis accounted for nearly 10 to 20% of all deaths in Europe. And as of 1989, when this particular paper was written, it accounted for nearly 7% of all deaths in the developing world. There's a doctor by the name Dr. John F. Murray, and he gave a lecture in the late 90s. And he highlighted in his lecture that tuberculosis was really not going away, but rather relocating to the tropics. And we will see in the epidemiology that this is true, because in the late 90s, tuberculosis was a problem of Europe. And at that time, they were plagued by a lot of problems, including overcrowding, poor sanitation. There were a lot of wars going on, and tuberculosis was a big problem for them at that particular time. But with increasing quality of life for the patients, increasing health access to healthcare for majority of those patients, tuberculosis now shifted to Africa, the Southeast Asia region, where now those areas have trouble in terms of accessing healthcare, have trouble with sanitation, and also poverty. This is a painting that was done by the artist Stefan. He was inspired by a gentleman that they saw on the street in New Delhi, and it really shows what a typical tuberculosis patient will look like. You can see his cheeks are sunken, his eyes look a little bit hollow, and this is what you typically expect to see in a patient who has tuberculosis. They tend to be wasted and emaciated, and tuberculosis is a disease that can be treated. And the reason we decided to discuss tuberculosis today is because it's not really just a disease of the tropics, but it is a disease that has a lot of aspects that result in its presentation. And one of them is the social economic status of patients. It also forms a really big and important differential in the tropical regions. And it also has quite a number of pathological aspects, which Dr. Zuriel is going to discuss. Globally, a fourth of the world population is known to be infected with tuberculosis. So that's roughly, say, 2 billion people are infected with latent TB, and around 5 to 10% of these persons will develop tuberculosis at some point in their life. According to the global report by WHO in 2023, they found that 10.6 new TB cases were reported, which translates to an incidence of 133 cases per 100,000 people, and 1.2 5 million deaths were reported in that global report. Among these patients, 161,000 persons had HIV. Tuberculosis is the leading cause of TB from any single infectious agent, and it has now overtaken COVID, which was previously the most common cause of death in 2019, in 2020, and 2021. It's also the major cause of death that is related to antimicrobial resistance. When we look at the global prevalence of tuberculosis, Southeast Asia, among the new cases that were identified in 2023, made up 45% of all the new cases, followed by Africa and the West Pacific region at 17%, and 30 specific countries were found to carry 87% burden of all the new cases that were identified. And the impact of tuberculosis is quite high because more than 50% of persons treated with TB and their households will face a total cost of treatment that is catastrophic, while more than 20% of their household income goes into treating tuberculosis. Additionally, 80% of these cases and deaths were recorded to occur in low and middle income countries. So this map highlights the incidence of TB that was recorded in 2022. And you can see from this map that majority of the cases were, the incidents exceeding more than 500 were mostly in the sub-Saharan region. Between 300 to 499 were mostly in the West Pacific region and a little bit of Asia. And in these areas, from what we discussed earlier, what we now refer to as the tropical areas. So these are the 30 high burden TB areas. And again, you can see that majority of these countries are in the tropical regions. We have most of them being in sub-Saharan Africa. We have a big chunk of it in Asia. We also have some of it in the Southeast Asia region and also in the South Americas. And this second map highlights the three watch list countries, which are, we have Zambia, we have Zimbabwe, we have Russia, and we also have Cambodia here. And the areas that are highlighted in brown are now the areas that fall within the tropical region. And these particular countries fall in the 30 high burden TB areas. So in 2022, again, 10 particular countries had the highest burden of disease. And you can see the major ones are again in the Asia region and in sub-Saharan Africa. And the biggest one was in India, followed by, we also have China here, we have the Philippines, we have Pakistan, we also have Nigeria, we have a spot here in Kenya, and we have it in Tanzania as well, and the Southern African region, as well as in the Southeast Asia region. And these are the global trends in the estimated number of TB cases in the region, in the time period between 2010 to 2022. And you can see that the incidence of disease had gone down, and it peaked again between 2021 to 2023. And this might have been due to underreporting because a lot of focus was being placed on COVID at that particular time. Again, you can see the rate per 100,000 people per year. We can see here that the incidence had gone down. It was between 120 to 210 in 2010. It went down to, the minimum was recorded in 2019, where the incidence was between 125 to 140, and it has almost remained steady after 2019. But the number of cases have been reported to increase in the past 3 to 4 years. So cutaneous tuberculosis falls under the big umbrella of extrapulmonary tuberculosis, and extrapulmonary tuberculosis accounts for 15 to 20% of all cases of tuberculosis. According to the global WHO report, more than 17% of the 7.5 million case notifications were extrapulmonary tuberculosis. And out of this 17%, 0.1 to 0.1 to 1 to 2% of these cases were cutaneous tuberculosis cases. According to studies done in India, cutaneous tuberculosis represents 0.1 to 0.9% of all the dermatology visits in India. And Chan et al. In India, in China rather, found that 1 to 2% of extrapulmonary tuberculosis cases were cutaneous tuberculosis. And quite a number of them have a coexisting systemic foci, with the lymph nodes accounting for 50%, the lungs at 35%, the bone 10%, and the abdomen at 5.8%. Regionally, Southeast Asia and South Asia, particularly India and Pakistan, have one of the highest TB prevalence that is recorded compared to the global averages. We have a lot of challenges when it comes to diagnosing TB, and this is because it has quite a number of clinical manifestations and is frequently misdiagnosed as being other dermatosis, which we will go through shortly. So by country, extrapulmonary tuberculosis was quite a number of cases were reported in the Americas and North Africa, and also in Australia. And when you look at the distribution of tuberculosis versus what is recorded to the extrapulmonary tuberculosis by country, it will appear that the regions that are the high burden areas and also the tropical regions seem to really underreport the cases, because there's really a huge discrepancy between the total number of cases of tuberculosis that are reported versus the extrapulmonary cases of tuberculosis that are reported. And one of the aims of doing our presentation was that by the end of it, we will be able to increase our clinical suspicion when it comes to identifying cutaneous tuberculosis, so that we can be able to identify it early and also to manage it. Some of the risk factors involved in cutaneous tuberculosis are, and the most common one is HIV. HIV is a very important predictor of tuberculosis incidence, and the two have been found to worsen each other. A patient who develops TB while having HIV typically tends to have deterioration of their clinical status. Administration of BCG vaccine, which is a common practice in quite a number of the sub-Saharan countries, has not been found to be effective in preventing cutaneous tuberculosis versus preventing other forms of tuberculosis. Some other comorbidities that place patients at risk of developing cutaneous tuberculosis are diabetes and organ transplants. And all these comorbidities typically will put a patient at risk of being immunosuppressed. And one of the most important factors in terms of how tuberculosis will manifest is how strong that particular patient's immune system is. Patients who have a stronger immune system tend to have what we refer to as a passive bacillary forms, while those with a weaker immunity are predisposed to developing multibacillary forms like scleroderma. Other determinants of TB generally, and cutaneous TB as part of it, are overcrowding and poor housing and ventilation, homelessness, poor nutritional status, and also education. One aspect that we have to consider as dermatologists is how biologics and small molecules play a role in tuberculosis as a disease. And we know that when administering biologics to our patients with psoriasis and other immune-mediated diseases, that we need to screen them for latent tuberculosis because of the possibility of the activation of the disease due to these drugs. In a Turkish cohort, Emin et al. Found the prevalence, or rather the incidence of tuberculosis to be 255 per 100,000 persons among patients who are receiving biologics for rheumatological diseases. And it is known that 0.1 to 0.2% of psoriasis patients who are receiving biologics also develop active TB at some point during their treatment. And so it is important to pre-screen them. So you can either perform a tuberculin skin test or do an interferon gamma release assay, do a chest X-ray, and also examine them clinically. And it is recommended that these tests are repeated every year. Among all these biologics, the anti-TNF alpha agents have been found to carry the highest risk of activation. going up to 25% compared to patients who are not receiving biologics, while other biologics like rituximab, the interleukin-12, 23s, and the interleukin-17s have a lower to absent risk of reactivation of tuberculosis. Patients who are found to have latent TB ideally need to receive prophylactic treatment before the biologics are administered, and this can be, you can either do a single regimen or do a combined regimen. The single regimen is 9 months of isoniazid, or do rifampicin and isoniazid for 3 months, which is what we do in our home country. Despite receiving prophylactic treatment, it has been found that 24% of these patients who are receiving biologics will develop active disease despite the medication. So your index of suspicion has to be very high, because one of the key things when it comes to tuberculosis among patients who are receiving biologics is that the disease tends to be quite atypical, and you might lack that typical granuloma formation that you will see in a patient who has tuberculosis. They also tend to have prominent lung fibrosis and a lot of lymphoid infiltration. So the pathogenesis of cutaneous tuberculosis is important because it determines how the patient will present clinically. So patients with tuberculosis will either, the disease will either be transmitted through the respiratory airway, or they could also acquire it through a break in the skin. So for majority of the patients, the respiratory route is the most common one. But for some particular types of tuberculosis that we will cover, the inoculation through the skin accounts for a very small percentage of cutaneous tuberculosis. So first you will have the initial infection, and when the infection, when you say acquire the infection exogenously through a break in the skin, the first responders tend to be neutrophils, because they are non-specific immune cells, and they will initiate the immune response and now recruit macrophages, which play a very key role in the pathogenesis of the disease. So when macrophages are recruited, they engulf the bacteria. Once they engulf the bacteria, they form a phagosome. But tuberculosis usually has a way of evading the immune system because it prevents the fusion of the phagosome and the lysosome. And so by doing that, it is able to continue duplicating inside the macrophage. And normally these macrophages, when not activated, have very weak activity in terms of killing the mycobacterium. So as the disease progresses, we find that the macrophage will now break down the bacilli and now present it to a naive T cell in the region of the lymph nodes. When it goes to the lymph node, it will now encounter a naive T cell and present the tuberculosis antigen on its surface. So when it's presented to a naive T cell, this T cell will differentiate. And when you have a Th1 cell being produced, it will result in release of chemokines, and especially interferon gamma and tumor necrosis alpha. Tumor necrosis alpha is one of the key cytokines in the pathogenesis of tuberculosis because it's important in terms of maintaining the structure of the granuloma, because the tumor necrosis alpha will ensure that the pathogen is locked in that granuloma structure that we will go through in our slides. Additionally, macrophages also secrete interleukin-12, and interleukin-12 again is important in activating macrophages. And as more macrophages are drawn into the area with the infection, they continue to proliferate and they differentiate into epithelial cells. And these epithelial cells typically tend to try to wall off the organism so that it can prevent further spread of the disease. So the end result is the formation of the granuloma. And in the periphery of the granuloma, you will have the T lymphocytes. And in the center, you might have a number of inflammatory cells in addition to the bacilli. And the center of the granuloma tends to be solid in nature, but it could liquefy. And when it liquefies, it allows proliferation of the bacilli. TB in terms of causing damage to the body is not through toxin production because it typically does not produce any endotoxins or exotoxins, but it rather causes a lot of damage because as your body tries to fight the disease, you have a lot of inflammation in that area, and in the process, you tend to have a lot of tissue destruction going on. We have quite a number of ways of classifying cutaneous tuberculosis, and the one that is most commonly used divides tuberculosis into exogenous and endogenous cutaneous tuberculosis. Exogenous cutaneous tuberculosis represents the forms of tuberculosis that are acquired through direct inoculation of the mycobacterium, and this include the tuberculous chancre and tuberculosis verrucosa cutis, and some forms of lupus vulgaris. The endogenous cutaneous tuberculosis are the most common ones, and they usually result from spread from a pre-existing primary focus. And the spread could be either hematogenous or through the lymphatic system or contiguous spread from an underlying focus. And the types under endogenous cutaneous tuberculosis include lupus vulgaris. We also have orificial tuberculosis, acute miliary tuberculosis, scrophulodama, and tuberculosis gamma. One other way of dividing or classifying cutaneous tuberculosis is into the paucibacillary forms and the multibacillary forms. The paucibacillary forms are the ones that you will find in a patient who has a very strong immune system. And these ones are lupus vulgaris, we have tuberculosis verrucosa cutis, and the tuberculates. While patients who have a weaker immunity and patients who are immunosuppressed for one reason or another tend to have what are referred to as the multibacillary forms, which are all these other forms that are not the tuberculates or lupus vulgaris or verrucosa cutis. Tuberculates represent a form of cutaneous tuberculosis that really not due to the microorganism itself, but rather the immune system manifesting, trying to fight the infection. And so when you do a biopsy or when you try to culture these lesions, you typically not find any bacilli. The most common one is the lichen scrophulosora. We also have the papillonecrotic tuberculate and erythema inviratum. So this table shows the classification of cutaneous tuberculosis, and you can see how you can divide it into the various types depending on how the patient acquires it. But typically in a clinical scenario, it is really not easy to tell how a patient acquires a disease. And so what we try to do is try and assess the patient as a whole. So first you want to look at whether the patient is immunosuppressed or not, and then decide from that particular point how to go about trying to classify the disease. If the patient is immunosuppressed, they're more likely to have the multibacillary form, while if their immunity is strong and they do not have any underlying risk factor that could predispose them to immunosuppression, then they're likely to have the paucibacillary forms. So I would like to invite Dr. Zuriel to take us through the diagnosis and the dermatopathological aspects of cutaneous tuberculosis.
Thank you very much, Carol. We are going to graph and look at how we are going to be able to make a diagnosis. The first thing we need to have as clinicians, as physicians, is a high index of suspicion. After that, once you've suspected this test could be cutaneous tuberculosis, then we want to do histopathology, in which case we can also collect samples for culture. You'll be able to get a wet sample from the patient. It will be important to submit that for culture. The culture is quite tedious, and then the other one that is much more reliable and very useful is the PCR. We know that culture is a gold standard for making the microbiological diagnosis. It has a variable sensitivity, between 0 and 62.8% due to the sparsity of bacilli in the skin lesions. So the population of the mycobacteria on the skin lesions, it's its path. It's not as we find in the lab. The time for the culture is between 3 to 8 weeks. And the tissue or you can collect them the tissue. You can have pass or aspirate, as you can collect the discharge, or you can do a fine needle aspiration technique, and then you submit the material that you believe you have collected and wait for up to eight weeks to be able to get the gold standard. Skin biopsy is very important morphologically. We start by doing the routine H&E, and we look at the pattern of the inflammation. And classically, we are looking for the cacheating granulomas, which could be absent in up to 30% of cases of cutaneous TB. And likely is related to immunosuppression directly by the mycobacteria themselves on the immune system. So the macrophages are not able to mount a proper granuloma that we can see under the microscope. That's important. Then we do from H&E, then we do the special stain, zeolnescent stain for visualization of the acid-fast bacilli from material that has been submitted. Finally, now important, we have the molecular methods where we're using nucleic amplification testing on pass aspirates, tissue homogenites, where we homogenize tissue collected. This is able to detect Mycobacteria tuberculosis in cases that was a dead negative on routine test. So that's an important app in the diagnosis. The flow that we like to look at is a suspected case of cutaneous TB. We obtain a skin biopsy. We consider urgent tests. Then we proceed, plus or minus evaluation of the general patient to see whether we have enlarged regional nodes and stuff. Then we have histopathological evaluation with special stains. When you find if it's inconclusive with a high index of suspicion, you want still to start in management. If it's inconclusive, you do other tests. If they're all negative, you consider an alternative diagnosis like sarcoidosis or any other conditions that may be presenting as such. Once you have definitive diagnosis, if culture is positive, then you proceed with treatment. If presumptive diagnosis, you can do the nucleic acid testing or other tests that have been positive, then you proceed and assess response, and you start management. What is the role of the fine needle aspiration in cutaneous TB? It's an alternative to biopsy when not visible. Biopsy is pretty the most reliable. With diagnostic yield, like in scrofulioderma, it's pretty good. You can get the buds in 68%, although these are post-bacillary situation. In lupus vulgaris, you can have a 32, and occasionally in lichen scrofulio, you may be able to get. You may get granulomas, plus or minus caseation. You may be able to get the special staining, which may be positive in 18 to 40%. And some cases may give us well-forming granulomas. Limitations, we notice that for very hard lesions that you're not going to get liquid material, then you're not going to aspirate anything, like in varicose cutis. So we can look at how the aspirate looks like. The tiny particles up here. Yeah, the material that we can see up here, the dots, this necrotic tissue, the thicker clots we are able to see or coagulates. These are the granulomas. At a higher level, now we can see the necrotic areas or the caseous necrosis or the other lipid material. The tiny cells we see here, the blue or dark smaller cells, regular cells, these are the lymphocytes. The paler purplish cells that look like the sleepers or sleeper cells, these elongated cells, these are the classic histiocytes that we see in TB. So once you see this, you know you're dealing with a granuloma. You see they are coagulating around one area. Here we have nuclei palisading with cytoplasm at the center. So these are giant cells correctly put. And once you see this cytology, you are able to say, voila, we have these are granulomatous inflammation. Go ahead and do your special stage. You're able to see the red bacilli right there, where you see those small arrows there. And you've done your diagnosis, and the patient can proceed to treatment. The famous bacillus coach, they were described by our earlier scientists. They are very characteristic and have very characteristic morphology. Once you give us tissue, we are able to process it, and here we can see a very nice skin biopsy. You start with the epidermis, you can see is a remarkable, a very normal epidermis. The papillary dermis is usually also spared many times in non-ulcerated TB, and also in leprosy, we tend to have a grace zone, which is a clean zone just at the basement membrane. Here on the right, we can see an infiltrate. These are the dark, small, round cells. These are classic lymphocytes. On the left, you can see some. Bang at the center, dividing the two, you can see a paler area, and these are zone of interest. Once you see this pale area, you can see abundant cytoplasm, which is a slightly pinkish. These are the histiocytes. There's one round cell here. This is a Langhorne cell, and these are giant cell. These are coalescing histiocytes. So this is a granuloma. You have one granuloma there, separated by some lymphocyte bridge. You have another granuloma here, and possibly another granuloma here. So this is what, when you see this, we know this is a granulomatous inflammation. It's very characteristic of TB for this case, because you can see the lymphocytes and the plasma cells reacting at the center. These are young granuloma. In a few weeks, it will start having a fibrosis around it because of the tissue reaction mechanism to prevent what? Spread of the bugs to other areas. Fantastic photo there, and this will be the easiest one you can get. Others may not be as easy as these ones. Higher look, then you can be able to appreciate the horseshoe shape of this Langhorne cell, not Langerhans, but Langhorne. Here we can see the epithelial cells. They're elongated like a slipper sole. These are the histiocytes, and around them is snophilic material. It's actually their cytoplasm. There's paucity of the dark small lymphocytes. They tend to be at the periphery together with the plasma cells. Once we get this, we are sure we are getting a proper diagnosis. Then we do the special stain. We do the acid-fast bacilli, and we test, and we can see the red pencils. These are the Koch bacillus. And there we are. Majority of them are inside the cytoplasm, like this one. This is the cytoplasm of these histiocytes, and that's where we find them. They are here within the cytoplasm. A few will be outside, which is okay. You can see them within the cytoplasm. Once you find these are high population, you're happy. You've gotten a diagnosis for the patient. We will skip a few so that we can be able to see some of the cutaneous morphology. And I believe Caroline will go through the cutaneous morphology.
Okay. So I will go through the cutaneous features, while Dr. Zuriel will assist me in going through the pathological features of these diseases. Then we make the pointer. All right. So lupus vulgaris is the most common form of cutaneous tuberculosis, and one study done by Sharma et al. And one by Niraj et al. In 2023 reported it to be the most common one in India and Nepal, respectively. And it accounts for between 60 to 63% of all cases of cutaneous tuberculosis. It is a chronic and progressive disease, and it typically presents with slow-growing asymptomatic papules, which coalesce into an infiltrated plaque. the plaque will expand peripherally. So one end of this particular plaque, as one end is resolving, the other one is expanding, and the center tends to heal with formation of fibrous tissue, and so we will have a lesion looking like this, the one on the top right of top left of that image. So this is a typical lesion of cutaneous tuberculosis. And as you can see in this particular photo, we have a very well-defined plaque. And this edge of this plaque is defined by a lot of scaling. It looks indurated. We also have a lot of underlying erythema and this overlying yellow-colored crust. And the center of this plaque is atrophic in nature, and one end of this plaque appears to be sort of resolving. So this is what you typically see in a patient who has lupus vulgaris. The older literature reports that lupus vulgaris would be found mostly on the face, but the recent case reports report that lupus vulgaris can be found anywhere on the body. And this is because lupus vulgaris can be acquired through quite a number of ways. And so if a patient was to acquire it, say, by hematogenous spread, say the primary focus of the disease is in the lungs and they have spread of the bacillus to other regions, you might end up forming a plaque of lupus vulgaris on the legs or on the trunk. If you were to say have maybe a focus maybe in the lymph nodes, in the cervical lymph nodes, the patient might have what is now typically referred to as the liquid picture of lupus vulgaris with the lesions on the face and around the nose. So lupus vulgaris doesn't necessarily have to be on the face. You can have it form on any part of the body, but the typical locations are the face, the cervical regions, and the limbs. If a patient was to acquire the disease via inoculation, for example, this particular patient was trying to have a tattoo, and unfortunately, you can see that the disease might have been present in the needles that were being used in the process of tattooing the patient, and he developed lupus vulgaris lesions on that particular area. Picture number C shows what is referred to as the apple jelly appearance of lupus vulgaris, and it tends to be an indurated and very erythematous and softish lesion that can be found anywhere on the body. But one of the major characteristics is that it's not a complete plaque as you see, say, in tinea capitis. You have one side of the plaque resolving while the other side progresses.
Fantastic. Here we see again the skin. The skin has, it's thinner. The epidermis is thinner. Inflammation gets closer. Now it's kissing up to the basement membrane. Classically, you're still able to see our very nice granulomas. We have granulomas bang there, here, and here. So the pathology will more or less be the same. We have the obvious epidermal changes that are not diagnostic by themselves, but you need to be able to put the whole biopsy together. You may see caseous necrosis in fewer cases, up to 25% of cases. The granulomas are much more commoner, and vascular populations are usually very low, but we have to be able to acknowledge that.
In cases of scrophulodama, which is the second most common form of cutaneous tuberculosis, we will have these lesions typically on areas where there's underlying disease. And the most common region is going to be the neck, followed by the axillae and the groin. And it occurs due to direct extension of the disease from underlying TB lesions, be it the lymph nodes, the bones, the joints, or even the testicle in some patients. The early lesion tends to be a firm indurated lesion. Some patients present with subcutaneous swelling, which might vary in color from red to brown. And as the disease progresses, it ulcerates, and you end up forming these lesions that have sinus tracts. Some patients might have one lesion, while some tend to have them to have quite a number in the same region. And as they heal, they might leave behind keloids or retractions or heal with atrophic scarring. This is an example of a patient that has been managed in our facility before. And this was a patient who presented with a 1-year history of these plaques that were originally on the neck. And you can see there are quite a number. And as the disease progressed, he started it ulcerated, and it formed the sinus tracts. And you can see some of them have already begun to heal. This is the same patient. You can see he has lesions on the neck, also has lesions on the axilla. And a diagnosis of sclerophilodema was made based on a skin biopsy. And this is how he progressed in picture number 3 and 4 when he was put on treatment. And you can see how the lesions on the neck healed significantly with the treatment, as did the ones on the axilla.
Yes, so here we're going to see again the inflammation. This is an extension. This is a disease that is usually scleroderma. It's not primarily cutaneous, so it's an extension, as we have seen, and you see the deeper pathology is usually in the deeper part where we see the granulomas. So we are going to see large areas of necrosis. This eosinophilic material right here is a necrotic one, and you're going to find the granulomas in as usual. When we look at high power with caseous necrosis surrounded by quite poorly formed granulomas. The granulomas are not going to be the classic well-defined granulomas. You're going to find neutrophil microabscesses in majority or in a good number of these patients. Insinus tracts are affected by scleroderma. They may exhibit predominantly non-specific acute and chronic inflammation with necrosis of the center. In the epidermis, there is extensive scarring bands that may be found due to scarring and atrophic changes. So not every case you're going to be able to see a nice granuloma. Majority of cases you may miss. If you don't have a high index of suspicion, you may miss a diagnosis. However, these are the cases that you pass because of the necrotic material that may be found. These are the cases currently now we are going straight to molecular diagnostics.
Orificial tuberculosis is one of the rarer forms of cutaneous tuberculosis, and it typically presents with friable and painful erythematous papules and nodules that might ulcerate. And the most common type of spread of the disease tends to be autoinoculation from a primary focus, say a patient who has gastrointestinal tuberculosis or genitourinary tuberculosis or pulmonary disease. And most of these patients also tend to be immunosuppressed. So these patients will present with ulceration in the mucocutaneous surfaces, which could be in the oral cavity, and especially on the palate and the buccal mucosa, as well as in the nose, the perianal region, and in the genitalia. And the lesions vary in terms of size between 1 to 3 centimeters. This is a patient who we thought had orificial tuberculosis. We're not sure where the primary focus of the disease was, but on closer examination of this patient, she had some ulcers on the nasal cavity, and she also has what appears to be a lupus vulgaris of sorts, but it is possible for a patient to have 2 types of cutaneous tuberculosis coexisting. So for this particular patient, we suspect that this might have been the orificial cutaneous tuberculosis, and maybe with a little bit of lupus vulgaris in the perioral region. And this is one of the most common diseases that might be misdiagnosed, because if you look at these patients, I think one of the first things in an area like Kenya where leishmaniasis is not uncommon, your first thought might be this is most likely a cutaneous leishmaniasis. But as you assess the patient, do your microbiological studies, you find that, oh, there's some bacilli here and some granulomas here and there. And so this is one of the one of the diseases where you really need to have a high index of suspicion, and especially in areas that are endemic. Another one is the tuberculous chancre. It is not very common, and it's one of the types of cutaneous tuberculosis that are acquired via the exogenous spread. It's also referred to as a primary inoculation tuberculosis. And the typical scenario would be a child who's been taken for vaccination, and a few weeks after vaccination, they present with a nodule or a pustule or an ulcer at the site of infection, or at the site of vaccination. So the typical lesion is a pustule that might ulcerate, and the ulcer tends to be soluble and painless, and the edges are quite undermined here, as you can see. You might also have regional lymphadenopathy, and it might progress to other forms of cutaneous tuberculosis like scleroderma, lupus vulgaris, or even become disseminated tuberculosis and influence with scarring.
Great. The morphologies, we've lost the pictures here, but the classic diagnosis again. You're going to find neutrophilic infiltrates at the site of the inoculation, then formation of microabscesses and necrosis in the reticular dermis. Granulomas may be absent, and many times they're going to be absent because of the time stage. We are in the early stages of disease, so the granulomas have not come up yet. But they will be present in later time, as well as numerous amounts of bacilli. Remember, these are patients who have not developed any immunity against tuberculosis. Most. Yes, these are other examples of varicosa.
Yes, this is a patient that we also saw at our facility. This gentleman had presented with plaques on the dorsum of the bilateral hands and also on the volar aspects of the arm. And you can see they're quite verrucous in appearance. And while tuberculosis varicosa cutis is not very common, it's one of those very main differentials in.
I'm sorry, we are short of time. Maybe you can give us some last words and then.
Okay, last words. All right.
Fantastic. A summary of the pathologic features in cutaneous TB. It's important to be able to remember. Varicosa cutis, you're going to see pseudoepitheliomatous hyperplasia with marked hyperkeratosis, neutrophilic microabscess in the superficial dermis. There could be extension into the retina. Epithelial cells plus or minus giant cell formation in the upper dermis and the mid dermis too. And you're going to find well-formed granulomas. This, if the biopsy is not taken well, without fear, some patients will just take a small piece of biopsy, which will just take the pseudoepitheliomatous hyperplasia, which is not diagnostic of its own. So it's important to have a full thickness into if you can reach the subcutis, that is the better, so that we have a full diagnosis for the patient. The other features that we see in LV is typical tuberculoid granuloma. We have seen that with or without necrosis and secondary changes with areas of fibrosis. That is again characteristic. You can see also in SF, you're going to find massive necrosis and abscess formation. This is because, again, it's an inflammation that is tracking from inside to outside. So you're going to find not too good granulomas, but this is an important one that you're going to remember to do molecular studies. In LS, then you have superficial tuberculoid, periodontal granulomas, and this we have seen, like that lady we were not too sure. In PNT, you find a wedge-shaped necrosis in the upper dermis, surrounded by non-specific inflammation, tuberculoid granulomas, and obliteration of granulomatous vasculitis, and that is important in EL. You have lobular paniculitis with fat. These are the erythema induratum with lobular paniculitis with fat necrosis and vasculitis. And finally, in erythema nodosum, you're going to have a septal paniculitis, not a lobular, without a significant vasculitis, but you may find admissions granulomas. So these are the classic features. Thank you for attention that you've granted us, and we are glad to be able to present.
Thank you so much for sharing this information with us. I can tell you had a lot more to share, but unfortunately time was not on our side. We'll allow Dr. Imelda to ask you one question each, and then we can close.
Okay, so my first question will go to Dr. Carol. Could you highlight some of the most misdiagnosed neglected tropical skin diseases?
I would say, cutaneous tuberculosis really is not a neglected tropical disease, but I would say it's one of the most commonly misdiagnosed cutaneous disease in tropics. One of the most commonly misdiagnosed tropical diseases are leishmaniasis, and I think it's one of the most important ones for us. We also have Buruli ulcers, although that's not very common in our setting. The other one is mycetomas, which we also see quite a lot, and especially from the refugees that we see from the refugee camps that we also encounter. Leprosy is also another big one, although it's not very common in Nairobi, possibly because of the urbanization here. But in other areas like the border, the coast region, and also towards Tanzania, we find quite a number of cases. So that's a big one. Scabies, I think, is managed as a fungal infections in quite a number of places, or eczema, because there's no specific test to assess for scabies, even for us dermatologists in our practices. So I would say those are the most common ones that we encounter in our day-to-day practice.
Okay, thank you for that. So the final question will go to Dr. Zuriel. So are there any diagnostic pearls that you can share with us that distinguish infections such as cutaneous tuberculosis or leishmaniasis and deep fungal infections?
Fantastic. We had one nice case of deep fungal or deep bacteria. The important thing in cutaneous TB, apart from the obvious crofilodama, which you will be able to pick many times directly, is look for that quite keratotic lesion. Many of those keratotic lesions that we are going to be able to pick with excessive keratin formation, this tends to be tuberculous. These are slow growing things. In majority of fungus, then deep fungus, they are regional. In our setup, the deep fungus we're going to see is a mycetoma. They are more regional. The lower limbs are the most prominent, occasional the upper limbs. And you're going to have the deep that may have color. It may be dark, it may be brown, it sometimes is just reddish, but for deep fungal, you're going to be able to appreciate secretion of some particles from the sinuses. Without much particle and tending to respond well to antibiotics. Of course, this is going to be a nice clue for your bacterial peak. For leishmaniasis, this ulcer that is healing at the center and is trying to spread a little bit, it's been there, it's not growing to be a big thing. It's most likely in the exposed skin. Majority of this is on the head and mainly on the face. We're seeing that now. From like here in Kenya, we are finding a lot of leish, but they're coming on the hair, on the scalp. So you find many patients with scalp lesions. Some of them are even purulent. Do not ignore them. Pick a biopsy. Actually, I have quite a number of patients now from that region where you're going to find them on the scalp. Interesting. Thank you.
Okay, Thank you both so
Mm.
much for sharing your knowledge with us, sharing your time. The information will be available on YouTube, and for the part that we missed, I'm sure the slides will also be available for us to digest the information. So thank you so much, and thank you to our sponsors, CeraVe, Care for All, and the Ellis Foundation. So see you next month.